Radha ma'am, we can start, ma'am.
Okay. Big thank you to Pallium and thank you to Ayeko and all of you for giving this
Voice problem
opportunity.
and voice problem.
Can you hear me or not?
Yes, ma'am, you're audible.
But somebody else is also talking, I think.
I'm,
Maybe you,
yeah.
thank you very much, dear. So once again, thank you to all of you. Thank you to Almighty. And it's always a pleasure to do and things with Pallium because as we always say, we all keep learning together. Okay, every day, new things, we all keep learning. So again, today we are going to have for the next 40 minutes or so uh, information on what's palliative care. Why are we all talking about it? Okay, let me share my screen. Can you all see my screen?
Yes, ma'am.
Thank you. Okay, so as I said, we are going to see what is palliative care. Next, what does that word mean? Okay, it's a Latin word, but what we need to know is that what's the verbatim meaning for it? Pallium means mitigate suffering, take away suffering, relieve suffering, remove suffering. So that is what is the um, meaning for the word. Then next, why is that everyone is talking about palliative care recently? There's a reason for it. Okay. 100 years ago, what was that the whole medical team was, or the whole medical world was busy treating? 100 years ago, what was the main problem? What's the problem today? Can anyone tell? Anyone can unmute and say, or even type in the chat of your choice. One of you know, just keep track on the chat box. I will also keep, but if anything is missed, so that you can
Sure, ma'am.
update me.
Sure, ma'am.
Okay. So people can type or unmute and say also what was the main problem that the whole medical team was solving 100 years ago, and what's the problem today? Okay, 100 years ago, it was infection. Okay, cholera, typhoid, plague, different types of infectious disease were causing lot of issues all over the world, and that is what the medical team was treating. But recently, all of you are aware of this wonderful term NCD. What does that NCD means? Non-communicable disease. Okay, and what are they? You can name anything. I've listed here. You can add on more and more. Anything which is not communicated from one person to the other, like it's not an infectious disease. Okay, it could be cancer, dementia, any system like diabetes, hypertension. You can take system wise: cardiovascular, respiratory, renal, central nervous system. Every system you can label one disease in this category. Okay, and then the next thing is that the number of people, see the next number, no, this 1.5 billion and 61 million itself is little bit previous statistics. Recent figures say that about 73 to 75 million people are having some serious health related suffering due to these NCDs. Okay, see, 73 million people in the world means it's not a small number. And another important thing in that is, of that 73 million, maximum number is in low middle income countries. And that is something of big worry and concern. And they are expecting by 2035 or 2050 that can even reach 100% to be in the low middle income countries. So that is why everyone, especially in let's say low middle income, LMIC, or Those type of places, people are all waking up now, because if it is something is going to become 100%, should we not wake up? So that is one of the. So these diseases, no, they may be non-communicable, but they are not without issues. Okay. So, and the number is what is really alarming. And next thing, do they all see, like infectious disease means one time infection, medicine given, problem solved? Are NCDs like that? It is a long term issue. It stays and lives with them as long as someone is alive. So that is something we have to be aware of. So it's a long term problem, large number, and something needs to be done. Can we sit simply and watch everyone suffer? That's not right, not to be done. And we are here not to watch and see. We are here to see and do something to solve it. Okay, and then the last point, what is mentioned here is another factor of fact which has to be understood is death is inevitable. See, I'll ask you one question. Is there any place in the world where no one dies? Is there anything like that exists in the world?
No, ma'am.
Thank you very much. Really, really, I'm so happy. Even if you did not answer for my previous questions, this is something, this is like a wake up call and not to be scared. Okay. But as soon as I asked, someone said no. So that shows what that is a truth and fact we all have to understand in a nice way. There's nowhere in the world that no one dies. Okay. So it is one phase of life. So again, we all know one golden term now, quality of life. Yes, quality of life has improved. We want to keep on improving. We want to give that quality of life till the last breath. Why should we not get it? Okay. So that those are the facts, things which we have to all start thinking. So we all talk about so much about quality of life. So by giving good care and support and treatment till, see, treatment means it is not only cure, care is also treatment. See, when cure is possible, do 200% things to cure it. When cure is not possible, should you walk back or walk out of it and say, I won't do anything? No, you can do the same 200% with care. Okay, that is, these are facts and figures to be understood by all of you and slowly taken to the other people in our medical fraternity, to the public, to the community, to your family, to everyone possible, so that everyone is first aware, then starts working on it and helps to solve these issues. Okay, thank you for answering. Next, what is palliative care? It is to give total care for patients whose disease is incurable, control their symptoms, because symptoms are the problem makers. See, if someone will take cancer itself, okay, someone has cancer, that cancer part of it cannot be treated or it's in stage 4. They have severe pain, they have severe breathlessness because of that cancer. Should that be treated or not? And next thing, now when they know that cancer treatment is not possible, they are least bothered about it. They are more worried about the pain and breathlessness. So, someone who treats the pain and breathlessness is equally important, and it is our duty to do it. So, alleviating those problems or controlling those symptoms is also our duty. Okay, and then to give the best possible quality of life for the patient. Last one is more important. It's a unit. Okay, the patient or person who suffers plus the family or the carer. The carer could be friend, family, neighbor, anyone. So the best quality of life is to be given for the patient and the carer too. Okay, so these are very, very important facts to be taken from this session per se. Okay, And the definition, all of you can read from every book or anything. So just I've highlighted the important thing. So as I mentioned, improve quality of life, and it is for anyone who is facing life threatening or life limiting illness. This life threatening, life limiting, one slight difference or little bit of more information on give. Life threatening means example will be cancer, where because of the disease their lifetime itself is shortened. Okay, many times when they are diagnosed with stage 4, stage 5, you will be knowing maybe life expectancy maybe 6 months to max, or a year or 2 years, something. So someone is only 30-year-old. Were expecting to live till 85. Okay, but unfortunately, because of the disease, the lifetime. So that is life threatening. Next, life limiting means take an example of someone who has dementia, or someone who has some neurological problem. Before that neurological problem happened, they were doing everything by themselves. After that neurological issue, they are unable to do their own activities of daily living. So that is limiting their life. They did everything before, now they can't do. Either they need help, or they need support, or they need gadgets. So these two, anyone who has either a life-threatening or a life-limiting illness will be under palliative care. And the problem need not be physical alone. Physical, psychological, social, spiritual, all these issues also need to be kept in mind, considered, and managed. Thus, quality of life of both the carers and the patient both has to be improved. So this picture shows what I've been telling so far. See, on the left side, you have someone who is struggling with the disease. On the right side, yes, he is having all the problems of the disease. But see, on the right side, it could be a daughter, a wife, or anyone. That person is also equal. Is she having the disease? No. Love, affection, care. So that's what family is for. Whole life someone lives together. Okay. And then, so that's why the family or carer has a big role. We will see through the presentation, so much of benefit also is obtained from the family and carer. And it is our right and duty to look after them too. Okay. Am I going too fast, or is it okay? One of you just let me know. You want me to slow down, or can I
No,
carry
ma'am,
on in
it's
this?
okay, ma'am. It's fine.
Very good. Okay. Thank you. Thank you very much. Okay. And very
Okay, ma'am.
short,
Okay.
short history uh, about how palliative care started and things. It was Dame Cicely Saunders who was the person who started about palliative care. She was a nurse, so she started looking after dying patients. And that was not easy in many, many years ago. See, 1967. Even then, she had a lot of problems. No one was helpful, accepting, and things. All what you're seeing today only exists. See, life is only a cyclical phenomenon. Okay. So then, being a nurse, she couldn't be successful in conveying the message and doing or rendering palliative care. So, what did she do? She herself trained and became a doctor. Okay. And then, even today, there is hospice which she founded and which still runs. And then next to, there were a few more people who were all pioneers in bringing palliative care to the state what it is today. Next was Dr. Elizabeth Kubler-Ross, who was a psychiatrist in the United States. She wrote a book on death and dying, okay, which woke up many people's idea, information, because they all read the book and they came to know about it. So, and she is also well known for classifying grief, okay, which maybe you would have read or you will read in due course. And then the next person was Dr. Balfour Mount, a surgeon in Canada, who coined this word palliative care. Okay, and then from early 2000, it was initially in the United States where they recognized palliative care as a entity, and they started training doctors and nurses, giving them specific qualifications for palliative care. And then in the last 5 to 10 years in India, you have universities having palliative care as a specialty. And in the last 2 to 5 years, it has become part of the curriculum, both in medicine and nursing, that palliative care also has to be covered in the syllabus or curriculum of these two, both medical, all medical fields. Okay. And then next, some myths are still there,
Yes,
even though,
yes, yes.
even though,
Continue.
uh, even though we have all been talking about all this. So, what are the main myths? Still, many people think so. Or do you agree or disagree? Palliative care is only for cancer and AIDS. Is it only for cancer and AIDS?
No, ma'am.
Very good. Thank you. And is it only for end of life? Is palliative
No,
care?
ma'am.
Very good. Thank you. End of care, end of care is part of palliative care. Okay, it is not, palliative care is not
Yes,
only end of life. Okay, so those are things. Then where can it be done? It can be provided both in the hospital and at home. Okay. Only thing is that for providing it either in the hospital or at home, the team or the resources have to be met with. So like manpower, um, equipment, transport. So if you want to provide palliative care at home, there are some things which everyone has to think ahead. And providing palliative care at home is more appropriate because, see, from we saw from the beginning, life threatening, life limiting. That means what? They are normal. So if they are normal, they can walk, come to the hospital, well and good. But if they cannot, if their mobility itself is not possible, and you see these pictures where they are in a place where normal walking people itself is difficult to access. So for someone who cannot walk, what a challenge will it be? So in those type of situations, if the care can go to them, that is by providing home care, it gives them very many benefits. Okay, so these are pictures of home care services, what Pallium does in and around Trivandrum. Okay. Pallium has 15 to 17 link centers, and every day 7 vehicles leave from Pallium morning between 9 and 9:50. Within 9:15, they leave. Slowly, slowly. Initially, 2 years ago, we used to leave at 9:30, then 9:15. Now, 9:05, we leave. Even though we leave 9:05, we come back only for 35. Okay. So the thing is that the area covered is large, and then the number of patients, the 17 centers, I mean, each center has 200 to 300 patients. Okay. And then see everywhere. So when the team goes to the patient, many things are convenient for them. Economically also, it's better for them. And only thing, you have to make sure that you don't waste resources. You all have to go and see to know, and then we will utilize the resources in such a way that depending on what is the need for those type of patients they're going to see that day. If they're going to see all sick patients, a doctor will accompany the team. If they're going to see review patients, the nurse will go and review, and any queries she will contact us, and then we will guide her. And then if it is going to be a rehabilitation or physiotherapy team, then there's a separate team will go. So utilizing the resources, planning, managing, everything is so important. Team working is the crux of it. Okay. So that is some information on it. Okay. And then to whom, as you saw, is it only for cancer AIDS? No, it is for anyone with serious health related suffering. And that broadly, here what I've done is broadly I've to understand and remember and not miss anything. You can say oncological palliative care, non-oncological palliative care. See, many organizations also nowadays you'll be seeing many centers have, most of the cancer units have a palliative care. Is it only for cancer? No, it is for non-oncology also. So that's why if you put like this, all all patients who can be covered will come under this. Under oncology, all types of cancer, head to foot cancer will come in that. Under non-oncology, all systems again go from head to foot. central nervous system, cardiovascular, respiratory, renal, liver, anything, neurological, musculoskeletal, everything. So broadly, why I'm telling you all this is if you go in this order, you won't miss anything. All of you have studied. I'm not teaching someone who is in first standard, second standard. Okay. You've all got a qualification and you're all working. So you all know I'm not the first person teaching. And first thing, all of you start thinking that you just need streamlining. That's all. So that's why I'm giving this order so that if you go in this manner, you will not miss anything. Okay. So many types of patients can be covered. Okay. And then comes these few slides. Next few slides are quite important one. What are the principles? Okay. Identify symptom and manage them appropriately. Disease correction to the extent possible. See, these are facts. Okay. Because there are so many myths. I don't want to say all those things. People still think and believe palliative care in a different way. So disease correction is done. Okay. To the extent possible. Correct the correctables. Okay. Then psychological assessment and management. This is equally important. We'll see that in the next few slides why it is important. And already I told you in the definition itself, all four elements. That is what is total care. Okay. And hospice care, if and when needed, will be provided. Terminal care or end of life care, if and when needed, will be provided. Okay. And then what are the things like do's and don'ts? Neither hasten nor postpone death. See, these are things, no, when we read and see, it may look very clear and transparent. But when actually you see patients, you have, because emotion and things hide or cause a screen. So you have to always keep these principles in mind and reiterate to the patient and family as and when required. So neither hasten nor postpone death. Provide relief from pain and symptoms till the last minute and integrate psychosocial, spiritual aspects of patient care always. Okay? And affirms life and regards dying as a normal process and offer support system for patient until death. So that's what that end of life care is also part and parcel. Not only till end of life care, offer support system for the surviving family carer or whoever it is with patient's illness and in bereavement. So at the time of death, after death also, care has to be provided. And all these are done, not that I've just put in slides. Okay, I'll give you some examples. So what type of bereavement care does Pallium support? For example, if some patient is in end of life care is given both at home and in hospital. Okay, proper like with infusions. Infusion means subcutaneous infusion, or we have a special home care team both morning and afternoon. So these type of patients will be seen by that team with the doctor, or if the end of life patient has been seen and all orders and instructions have been given, the nurse will follow it up. Okay, so until like from the time when they are in end of life care, they'll be seen more frequently. Okay, and then after at the time of death, depending on the time and the time of the day and things, support will also be given at that time. And then after death, the patient is contacted, the nursing team will go see them in person. And after that, also, there is a group activity called Unarvu. Unarvu means feeling. So, in that group, people who have lost their kith and kin will come to that group meeting and they will get support from others who have gone through this, from Pallium, social welfare support, psychology support, and also by attending these things, they even become volunteers. They all come by themselves. No one forces anyone. They help each other. They start to become volunteers and help other families or other people who are going through these type of situations. Okay, so that bereavement support is also equally important. Next, when to provide. This is again is a like a gray area. Everyone says, "Oh, when, what?" End of life, we don't know. When to give, we don't know. So for that also, this graph will explain. And practically, as you also, when I used to work in Cancer Institute, I know that is a tertiary center. People from Assam to Kanyakumari will come there. Okay. So we started, I think in 2018, if I'm not wrong. We told them we'll start when the patient comes into the hospital itself. They'll be going through all their diagnosis part and thing. And from that time itself, we started seeing patients. So that is where it will be very helpful. So if you see in this picture, we'll go from left to right. More so, I'll give you the color. You see the light green one where it starts saying screening. Once again, is it all? Am I going okay? Anyone wants to ask anything or anything like that? Any burning query you want to ask immediately or something like that? Just answer if it's okay for me to just carry on or no. Okay? Or if anybody wants to ask, please do.
No, ma'am, it's okay.
Okay then. Thank you. So if you see this picture, on the left side, you have the light green one, which says screening. And then the bottom on course of illness, that is the time frame as time goes. Okay. So when someone has some vague symptoms, not diagnosed, they don't know what it is. So they are having all tests done. And at that point of time, they come into the hospital and then some diagnosis is made. At the time of diagnosis itself, you see the blue area is palliative care and the yellow area is curative care. So here normally we take example of cancer just to make things clear. You can take anything in this. Okay. So anyone who needs palliative care. Okay. So if it is cancer, so you have disease directed therapy like chemotherapy, radiotherapy, surgery. Come what may, whatever can be given for that, let them have. Okay. And God's grace, they get fully cured or they come into remission. Well and good. Okay. Then what happens? At that time, the palliative care contribution, because whatever team, for example, radiotherapy or chemo, everywhere, everyone is overburdened with the number of cases they see. So they may not be able to treat all the symptoms that the patient's having. So if they are able to see palliative care also simultaneously or hand in hand, though the main team will give chemo or radio, also some side effects they will tell. There may be more side effects which the patient is undergoing. Pain is pain and breathlessness, especially radiation means they can have some rash, some discoloration, difficulty in swallowing, many, many things. I can go on labeling. So those can be solved or treated by the palliative care team. Okay. And then if things get better, well and good. Not always it goes that way. They may get the treatment, but in spite of treatment, they don't get the benefit that they anticipated or they wanted to see. At that point of time, what happens? The disease directed therapy becomes very minimal. Then the palliative care, see, the blue component increases at that point of time. Because the curative component decreases, the palliative component increases. Okay. So, and then they may get to a stage where no treatment is having any benefit. It's causing more harm than benefit. Okay. So then it becomes fully palliative care. And then they may go into the phase of end of life care. Okay. So, and as I already told, at the end of life care, you'll have death. And then after that also, bereavement is followed up. Okay. What I explained. So this graph, all of you need to get it clear. So if anybody wants me to explain once again, I will do. If so, please let me know. Clear? Okay then.
Yes, ma'am. Clear.
Okay. So this one, it's a case because as I said, no, if you see a 38-year-old male who is diagnosed with CA of the oral cavity, he is the breadwinner. He's married, who has two children. They are 9-year-old and 2-year-old. Wife is a housewife. She doesn't go to work. And unfortunately, he needed surgery, radiotherapy, everything. So he is unable to go to work. And he is so much fatigued because of the treatment. He lost nearly 25 kilos of weight because he literally couldn't eat oral cavity, no. So they put him on NG tube, tried everything, but still. And then even after surgery, took a long while. We suggested so many protein supplements, natural supplement, because affordability also is there. So with all that, it took him 6 months, 8 months to get back on his feet, to stand, walk, at least to ride a cycle. Okay. So what was the most bothering thing in his mind? The last point. Who will pay my children's school fees? Who will give money for my family to get their daily living? See, yes, he had the disease. He had all pain, everything. But these, this financial, this is what is social pain or psychosocial pain. And on top of it, he has psychological also. Okay. So this case I have listed here for all of you to think physical, all those four components, which you'll see in the next slide. See, these all four components have equal role. Can someone tell me, like physical, what were the problems he had, and what is someone of that with those history can have?
Pain.
Yes.
No.
Swallowing difficulties. Because see, of the oral cavity, no, they may have drooling, they can have ulceration. I'm just giving examples like you
And
were all
breathing
seeing.
out problem also, ma'am.
Yes, exactly. They can have breathlessness. They can pain, as they you listed, pain is pain, fatigue, breathlessness. Those are all physical. Emotional, what all can he feel?
Nikki.
Emotional thinking about his family, madam.
Exactly. Then he
Financial problem.
Spiritual, believe in God, not believe in God. Why, Guru?
Ma'am, you are on mute, ma'am. Radha, ma'am. Radha, ma'am. You are on mute, ma'am. No, ma'am. We can't hear you, ma'am. Okay.
can you hear now?
Yeah. Yes, ma'am.
Something like my screen froze for a minute.
Yeah.
That's
Okay.
okay. Did you want to ask anything? Did anybody want to ask anything? Can you hear me, dear?
Yeah. Yes, ma'am.
No, did anybody want to ask anything or?
You are asking some questions, ma'am, about
No,
the
that's all.
blood and all. So they're asking weight loss.
Uh,
They're saying weight loss, fatigue, and
yes, exactly. What all will they see?
yeah.
Yes, yes. Wait, correct, correct. Immunocompromised. Okay, let me go back to, yes, thank you. Suddenly my screen just froze. It was not moving at all. That's why let me come back. So, okay, this is where we were.
Now it's
So,
fine.
so basically, that spiritual component, many may feel,
Spiritual
oh,
component, believe
uh,
God, not believe
uh,
God.
Hey, hey,
exactly.
hey.
Maybe I did something wrong, so I am getting punished. It is my fault. So, guilt feeling. No one is punished or anything like that. But unfortunately, when we go through those phases, so why me? I did everything good. Now I am punished like this. So those all will come under the spiritual component. For that also, once we finish our slide, I will ask you some questions and we'll have some clarity on that also. Okay, so these are all the various components. Next, as we have all been telling, pain and breathing difficulty are the two common, serious, troubling symptoms. Okay, and it is our duty to alleviate both of them. Okay, if someone is in pain, it's agony, it's not nice. Okay, so we have to make sure that pain and breathlessness are treated as well as possible. Okay, and opioids can be beneficial to treat both. Okay, so you should, through your sessions, what you'll have, you will know what dose, when to use, how to use, and things like that, which will help. And then by doing so, it is our duty, and that will give the best care also to the uh, patients. Okay, and then next, what we're going to see is what are the big difference between hospital-based care and home-based care. In hospital-based care, everything is available under one roof. You enter one big campus, everything you want happens there. Doctors, social workers, psychologists, physiotherapists, many dressing needed, like rehab, everything can happen under one roof. Okay, so that's the benefit of getting to a big hospital. But is there a big hospital access to everyone? It'll be a big no. Only very small percentage of people have access to big hospitals. So does that mean who cannot go to big hospitals should not get any treatment? They also can get the best treatment by providing home care. Okay, palliative home care service can be provided. As I said, we have to train people in all fields, and as I was telling about it with the picture previously, so only thing is, just give me a minute, 1 minute. Literally, just give me a minute. Someone is knocking my door. I'll be
Sure,
back in a
sure,
minute.
sure, ma'am. It's fine.
I'm on an online session. Go ahead.
Might delivery later on today evening.
Huh.
Okay. First he say now, come. He say now, today afternoon. My park bags are ready. Be come tomorrow. Okay.
So today you'll go and come back later.
No, no be going because no delivery coming. Delivery coming afternoon.
You'll come.
Tomorrow.
Okay. No.
Thank you.
Sorry about it. There's some work going on, so there were some workmen who wanted to go. Okay.
It's okay, ma'am. It's fine.
Thank you. So basically, when you're going to provide home care, no, preparing for it, training the team. For example, not only the doctor, nurse, you need a full team. So what we generally say is, if you're going to start home care, minimum 3 people are needed. Okay, one doctor, one nurse and one social worker. Because see, in this last 10-30 minutes, we have seen how physical, psychological, social, everything is equally important. So the doctor and nurse will look after the physical symptoms. If you have a social worker, they can do the assessment of their psychosocial situation. And then that is bare minimum. If you can have a psychologist, well and good. Okay. So minimum you need a doctor, nurse, and a social worker. Then at least the psychologist know you can refer that patient to a nearby service. But without these three basic things, your care provision may not be very good or complete. So that is why you need these, at least these three. Okay. And then in this next slide, what we'll see is why or what are the benefits of doing home care. See, this here I've given it as two sides. One is from patient's point of view, another one from carer's point of view. Okay, from patient's perspective, they are in their own place. They are happy. How many patient or person is happy to be in the hospital? Many are scared. Of late, people say, I don't want to go to hospital itself. Can anything be done at home? So, first thing that gives them comfort, no fear, and then that gives them so much of confidence, self morale, and things will be better. That itself will be part of their healing. That emotional component is solved by that. Okay, and then they have their family around. Okay, and then from because many times in hospital no one is allowed, so they'll be by themselves. Even whether they are in pain, all that will be taken care of. But the emotional component may not be met when they are in hospital. So from carer perspective, if you see everyone, the like in the picture we saw the suffering person and the wife or daughter or someone. So there, the family is happy to be part of the caring team. And we can teach family many things can be homemade. When you all do the course, you will know that mouthwash, dressing material. We teach making all these at home itself in such a sterile condition, not that it is in part to what is bought. Okay. And we have been doing this, as I said, from 2018, all these 7-8 years, we have been teaching, doing, and I've seen patients use those things and get better also. Not that only book information we are giving. Okay. So all this is practically possible. So by teaching, you reduce the financial burden also for them. So all those, see, for example, simple mouthwash. Rather than buying, they can make their mouthwash at home. I'll give a simple that I will tell afterwards once we finish. Okay, so these type of things can be taught, and then various aspects can be covered. And having family as part of the caring team is very beneficial for the patient and for us too. Last but not the least is rehabilitation. Okay, depending on what or how the patient is. As I said, no, life threatening means the surviving family needs rehabilitation. If it is life limiting illness, the person itself, once they get to a stabilized condition, they themselves can be trained according or based on their skill to what is possible, either to have some small scale industry or do things which they will be interested in. So, finally, being a palliative care provider, you're also going to be one of this. You can be a health educator, do awareness sessions and things both for the patient, family, and society. You can be a counselor or psychologist. You can be a messenger conveying some important information between a patient, family, doctor, society, everything. Why not? You can be an advocate also to bring forth what are the important changes or things required. And then finally, everyone will be a caregiver at some phase of their life. Either you could have been a care provider, or you may be a care provider now, or you may be someone who needs care at some phase of your life. Okay, so all these roles are interchangeable. Okay, thank you very much for patiently listening. 1 minute. Few things what I was mentioning was what when we were talking about spiritual pain, what is religion? What is spirituality? Anyone can say. What do you mean by religion? What do you mean by spirituality?
Religion means Hindu, Muslim, Christian, any other, madam?
See, not to be so like a little bit diplomatically, I will tell. Religion is faith, belief, custom. Nothing wrong. See, as I always said from the beginning, this is a platform where we all share information and we are happy to um, discuss and move. So it is religion means faith, belief, customs. What are things which are followed? Exactly. Based on that only, you said all that. Okay. So why I said so is because we are not talking anything like that at all. So it is those belief, customs, and practices will come under religion. Okay. What is spirituality then? Go ahead. What do you mean by spirituality? Because in that, when I was asking, you all said something which was very relevant. When you say spirituality, what do you mean? What do you mean by it, the word spirituality? Anyone can say. Okay, that means meaning of life, purpose of life. What is that? What is that you want to do? What do you think is the meaning of your life? Why am I living for? What am I living for? So that's all. This is something more than religion. So that's why we say someone could be religious but not spiritual at all. But someone could be spiritual but not religious at all. Being religious might help you to become spiritual. Okay? So all these three statements are true on their own and nothing is wrong. So that's why, as I said, no, from like for the spiritual component, even for that we can help them. How? For example, we'll take someone who was a very ardent or devout Christian, okay, going to church every Sunday, not even miss one Sunday. Suddenly he's unwell, he can't go. How bad they will be feeling. So, in those situations, what we can do is either get the help of that church where he goes. So, the father in that church may come round to his house. They may be very much willing. Or today's world, as we are all attending, they may do an online session for him. He can attend some online mass or prayers of that church. So this is how. So that will take away or ease that spiritual component of pain or discomfort. So I gave this example. The same thing can be followed for any religion they follow. Because that has a big role. Because they may be punishing themselves, which is not required. So, okay. And then the next thing what I said was, preparing some homemade thing. No, I'll just give an example with the mouthwash. We can do saline at home. We can do dressing material. Those are all will be taught in your. How many sessions are you going to have for this batch?
We have total 19 sessions, ma'am.
So in that 1-2 sessions, you will have one
Sure,
entirely on
ma'am. Yeah.
home-based thing. But I'll just give an example. For example, mouthwash, 200 ml. Okay, just take nice hot water to lukewarm temperature. Add 1 pinch of salt, 1 pinch of soda bicarb, and to add flavor to that, you can do few things. Either 1 or 2 twigs of mint. I'm giving so many choice. You can pick one of them. Or you remember this polo mint used to come with one hole in the middle? You can put one polo mint in that one glass. Enough. Along with, see, 1 pinch of salt and 1 pinch of soda bicarb must. That you don't change. And all the other things, flavoring, I'm telling is to add different flavor different days. Or one cardamom, one clove. So anything. But you use that 8 times in a day, 6 to 8 times in a day. One glass, prepare at that time. See, no need to store, no need to get big containers, no need to waste money. Water, salt, soda bicarb, everyone has in their cooking kitchen. And if they use that, anyone with oral cavity CA, they have the sticky mouth. They won't be able to eat. They'll have oral thrush. All that will go away. If they do this 4 to 6 times or 6 to 8 times in a day, by third to fifth day, they will feel better and they'll eat better. So many type of homemade things it can be taught, and whatever they save, no, they will use that to buy food for themselves, either for themselves or the family. Many things like that. Okay, so many things like this can be taught. Okay, coming to anybody wants to ask any queries in what my presentation, and I've already shared my presentation, and you can share it to the group.
Sure, ma'am.
Anybody wants to ask anything, please go. All of them are nurses, or what?
All of them are nurses only, ma'am.
And which area you're all from?
North side, ma'am. Most of them are from north side.
Various
Okay.
districts.
Various districts of the north.
Various states also.
Okay, ma'am. Thank
One
you.
state? One state or different states?
Different states.
Different state. Different
Very
states.
good.
Some of
Good,
them
good.
are from Kashmir, some of them are from Sikkim,
Okay.
Haryana. So,
So that's all. So basically, that's why this homemade, will be very, very useful for all of you. Because I have been to Gangtok, Sikkim 4-5 years ago. So see, what I showed pictures, are nothing different from where all of you are. Okay. So every part of the world is the same. See, little bit of maybe in Trivandrum they are speaking Malayalam, there they'll be speaking whatever Assamese or whatever is their regional language. That's all. End of the day, we are all human beings. We are all the
Yes, ma'am.
same.
Yes.
So that's all. So try to tailor make it to your need. This one size fits all, doesn't work. So everything you take, and then we do give the information. So you have to make it convenient to your area and situation. That is the important. We all have that capacity and potential to do it. So we have to put the mind to do it. That's all. Very, very good.
yeah.
Anything else they want to ask? Let them ask. Otherwise, go ahead. Back to you.
Please ask. One is responding.
Hey, this is the first day, no? So
Yeah, yes, ma'am. Actually,
naturally.
yeah.
So it is that, and
Mr. Naveen, are you asking something?
बायोमेट्रिक लगा दें चलो
No.
कर ले किसी की हो
They're talking
ले भाई
something
फोटो डॉक्टर डॉक्टर
of
को
the
ना कि तुम
subject,
क्यों
I
लगा
think.
खाओ
Dear participants, how was the section? Please respond.
This is very interactive session in between there. Respond very well.
And the remedies are too good, ma'am, actually.
no. Now, see, as I said, being the first session, no, so much
Yeah,
information and gathering, and as they go, and then always getting in touch with Pallium, you will be able to get support and things as and when required. Okay.
sure,
Over
sure.
to you, dear.
Thank you
As
so
I
much,
said, you
ma'am.
can most welcome,
Yeah,
and you can share the PPT to them.
yeah, sure, ma'am.
Thank you
So
so
I'll
much.
upload that PPT on platform so they like have the access now. Yeah.
It was very good and informative.
Thank you
So,
very much, and good luck to all of you. Hope this care and service provision reaches the public where and when it's needed.